welcome to Voices of Wisdom, TIRO's podcast designed to share thyroid cancer pearls of wisdom from clinicians for clinicians. You can think of it as kind of a fireside chat where we talk to international experts who share their wisdom and offer practical advice to clinicians in a variety of common and sometimes complex clinical scenarios. I'm your host, Dr. Dana Hartl. I'm a head and neck surgeon at the Gustave Roussy Cancer Center in France, and I am very excited to be your host of TIRO's Voices of Wisdom podcast. I will be hosting this second season of Voices of Wisdom, stepping into the shoes of Dr. Janice Pasieka, who pioneered these podcasts. I want to take this opportunity to thank Janice for all of her hard work on making these podcasts a reality, and congratulate Janice and all of those who contributed to the success that they have become. In each podcast, we will be meeting with one or several international thyroid experts, and each episode will dive into a specific topic related to thyroid cancer care. Our aim is to help clinicians deal with issues that are often complex, and our aim is to provide as much evidence-based information as possible, but also practice-based information and tips from world-renowned experts. In each episode, I'm joined by a distinguished international guest who brings their unique perspective and expertise to the discussion. So whether you're a surgeon, an endocrinologist, a pathologist, a medical oncologist, or a nuclear medicine specialist, this podcast promises to be a pivotal resource in your quest for knowledge in the care of thyroid cancer patients. Today is the first episode of our second season, and I am thrilled and honored to have my colleague and mentor, Professor Martin Schlumberger, with me to debunk myths surrounding thyroid cancer and nuclear energy and radioactivity. Professor Schlumberger is a renowned nuclear medicine specialist and endocrine oncologist at Gustave Roussy and emeritus professor at the University of Paris-Saclay. And he's a consultant and expert in health hazards of radiation as it pertains to the thyroid. So this is really an honor for me. Let's get started. Professor Schlumberger, thank you so much for joining me today. We all know that exposure to radioactivity can be a risk factor for developing thyroid cancer, but it's not just any kind of exposure that causes thyroid cancer. And so we have lots of patients that come and say, well, I'm sure my thyroid cancer, it must be because of a nuclear reactor near my house, or my parents told me when we were in Europe when I was young, when the Chernobyl accident happened. What do you say to a patient like that, Martin?
What I answer is extremely simple. First, that all epidemiological studies have clearly demonstrated that radiation can induce thyroid carcinoma. And this includes nuclear bombing in Japan, Hiroshima and Nagasaki, medical exposure to external radiation, and also exposure to radioactive iodine. Now, all kinds of radiations can induce thyroid carcinoma, but there are at least three parameters which should always be taken into account. One is the latency period. Thyroid cancer occurs only more than 5 to 10 years after radiation. Second, the most important parameter is the dose of radiation. The dose should be over 100 milligray to induce thyroid carcinoma. So just a reminder that the natural irradiation is between 2 and 3 milligrays per year, that the CT scan delivers about 5 to 10 milligrays, a PET CT of 10 to 15 milligrays, and a chest X-ray 0.1 milligray. So 100 milligrays represent at least 10 CT scans. So it's a significant amount of radiation. And the third point, which is extremely important, is that young age years at exposure is a significant parameter. So the sensitivity to radiation for thyroid carcinoma decreases with age, and after the age of 20-25, the risk is very small or insignificant. So a patient to develop a thyroid carcinoma or to establish a link between radiation exposure and the occurrence of a thyroid carcinoma should meet at least two characteristics. One is exposure during childhood, and the second one is that the dose to the thyroid gland should be over 100 milligrams.
Okay, that's good. So that's why that we really don't know how often, but pediatric cancer patients are followed up for thyroid cancer. So do you think people living like near nuclear plants should be screened for thyroid cancer? Is there enough radioactivity in the environment? Does environmental radiation do anything?
I'm sure that they should not be screened. The excess dose of due to the nuclear power plant in normal conditions, I mean outside any accident, is some microsievert per year. So it is totally insignificant. Remember that the natural radiation exposure is between 2 and 3 millisievert per year. So this is 1,000 times less than the radiation exposure. And this cannot induce any damage, including thyroid carcinoma or any kind of leukemia or cancer.
So that's reassuring. So environmental radiation isn't, and I imagine taking an airplane, that's also minimal radiation.
Travel between Paris and New York is delivers about 10 microsievert. Okay,
so we're way below.
And a millisievert or milligray, which is the same, is 1,000 microsievert.
So we're talking about just very low exposure to radiation. Okay, so that we can reassure patients that environmental radiation is not a cause of thyroid cancer. And then the other question was raised that there was an increase in clinical thyroid cancer and incidental thyroid cancer in children exposed to Chernobyl, but then there was, and also in children after Fukushima. But it seems like there was a kind of a difference in between what we saw in the patients exposed to Chernobyl and those in Fukushima. Can you explain why there's that discrepancy?
Yes. So Chernobyl was in 1986, and a huge amount of radioactive isotopes have been contaminated Belarus, Ukraine, and southern Russia. The mean radiation dose in highly contaminated countries was 580 milligrams, 580. And in 4 years later, there was an increase of thyroid carcinoma in young children who were below the age of 10 or below the age of 5 at the time of the accident. And between 86 and 2005, about 7,000 thyroid carcinoma occurred in these highly contaminated regions. These thyroid carcinomas were extremely aggressive, with frequently enormous masses in the neck, with lymph node metastasis and lung metastasis in 40% of cases. When they occurred some years after the accident, I mean in the 90s. And after this, when carcinomas occurred in older children, they were less aggressive, smaller, with less frequent lymph node and lung metastasis. But still, there is an increase in the incidence of thyroid carcinoma. Now, since 2005, it is difficult to know what is the reason why there are so many thyroid carcinoma. Is it due to Chernobyl, or it is the natural incidence of thyroid carcinoma which increases in normal subjects with age? So in Chernobyl, undoubtedly, there were a lot of thyroid carcinoma occurring in young children after the accident. Now, in Fukushima, the situation was extremely different because the dose to the thyroid was extremely low compared to Chernobyl. The maximal dose to the thyroid gland was 35 milligrams. And almost 95% of children received a dose which was less than 1 milligram. So were not irradiated. This was due to the iodine diet, which is extremely important in Japan. It was also due to protection measures taken by the Japanese government immediately after the accident, which was not the case after Chernobyl. And there was no increase in thyroid carcinoma. But the Japanese authorities decided to screen all children below the age of 20 years at the time of the accident. So this living in Fukushima district. This means that 300,000 children are screened every 2 years with naked ultrasonography. And in 2014, about 33 cases per 100,000 children were found. But these were small thyroid carcinoma, totally unknown and without any clinical consequences. So the picture is totally different from Chernobyl. In Fukushima, the thyroid carcinoma found with screening are small and probably related to screening and overdiagnosis, whereas in Chernobyl, the children found some years after the accident were extremely aggressive. So I think that in Fukushima, the thyroid carcinoma were found by screening and not due to the accident. But in Chernobyl, of course, these carcinomas were due to radiation exposure due to the accident.
Okay, that's interesting. So that really means that it's dose dependent in a large part. Is that what you're saying?
It's totally dose dependent.
And then the more aggressive, bigger tumors we saw in younger children that got those big doses of radiation after Chernobyl.
Yes. And probably the aggressiveness of the Chernobyl cancer were due to the young age at exposure. And in fact, the few young children we had in Guildreef, which were not irradiated before, but were younger than 10 or 7 years, had aggressive carcinomas. So there is a direct correlation between younger age at diagnosis of the thyroid carcinoma and aggressiveness of this carcinoma.
Okay, but so does that mean that radiation-induced thyroid cancer in younger patients is more aggressive? Do we have data on that?
No, well, any thyroid carcinoma in very young children is more aggressive than thyroid carcinoma in older children. And the age limit is between 7 and 10 years of age. So over 10 years and after 14 years of age, thyroid cancer is like in adolescent and young adults. So it means very, very poorly aggressive, but in younger children, it is aggressive, radiation-induced or not.
And so radiation-induced disease isn't really different from non-radiation-induced.
It is very similar, very similar.
That's really interesting. It's great to have those clear parameters about the dose and the age of exposure. So what do you say to a patient who says, oh, is my thyroid cancer related to a radiation exposure?
I say, well, the dose of radiation you received was probably very low and too low to induce any thyroid tumor. So this is the first point. The second point is that radioactive iodine, and mostly radioactive iodine 131, has an half-life of 8 days. And after 10 half-lives, there is no persistent radioactivity. So there is no risk of contamination. So after 3 months, there was no contamination due to radioactive iodine. So this is the second point. And the third point is that when the dose to the thyroid gland is over 100 milligrams, this can induce in children thyroid cancer, but this is the only cancer directly related to radiation exposure. And we can prevent the radiation of the thyroid gland by sheltering, by evacuation if necessary, by restricting diet of contaminated food, and by giving potassium iodine to protect the thyroid. So we know how to protect the thyroid gland in case of a nuclear power plant accident. And if we can protect the thyroid, we can avoid thyroid irradiation, and then we can avoid any thyroid carcinoma.
So that's what you would say to somebody who's living near a nuclear power plant, for example.
I would say to a person living in normal conditions, there is absolutely no risk. But if there is an accident, the authorities can prevent any radiation of your thyroid gland. So don't be anxious. Don't be anxious.
Okay, so there's not enough in a normal countryside in Western world. The environmental radioactivity is not enough to cause thyroid cancer. So how can we be better at communicating that to patients? Do you have any ideas about that? To say no, it's not radiation.
Well, this is based on epidemiological studies. So you count the number of thyroid carcinoma in people who have not been irradiated and in people who have been irradiated. And then if there is a difference, you can say that the radiation exposure has induced some thyroid cancer. So this is the first point. The second point is that in molecular biology has shown that radiation-induced thyroid carcinoma has frequently gene fusions, including RET fusions. And this is a characteristic of radiation-induced thyroid carcinoma, whereas non-radiation-induced thyroid carcinoma frequently harbor point mutation, BRAF or RAS point mutations. So one characteristic of the radiation-induced thyroid cancer is that fusion is much more frequent in this thyroid carcinoma than in non-radio-induced thyroid cancer. The treatment will be the same, and the prognosis for the same histology, for the same stage as discovery, etc., for the same age is exactly the same in radiation-induced and in non-radiation-induced. And as you know, most of these thyroid carcinomas can be cured by surgery mostly, and sometimes by surgery and radioiodine treatment.
That's great. So we can definitely reassure patients who don't have any medical history of irradiation or weren't exposed to any radiation catastrophes that their tumor is probably not related to radiation or radioactive iodine.
More than probably, certainly.
Certainly. And then the prognosis in any case is very good.
Yes.
I think that's really important for physicians to know that there's really this dose and age relationship, and they're really big doses, because I don't think we realize the relativity of what radiation doses are.
Yes, I would add one final point is that screening for thyroid carcinoma should not be performed in normal population, not at risk of developing a thyroid cancer. If there is a population of a person who has received a dose higher than 100 milligrams, of course, he can be followed and screened for thyroid carcinoma. But in the general population who has not been irradiated, there is no reason to screen for thyroid carcinoma with neck ultrasonography, with neck palpation, with etc., because this leads to overdiagnosis, to the discovery of small thyroid tumors, small thyroid cancer, which, if not discovered, would not induce any symptoms or death of the patient. So the problem of overdiagnosis is that it leads to overtreatment, and overtreatment can induce psychological damages and also morbidity, as you know, and cost. No screening.
I think that's the take-home message for today. One take-home message, that it's not related to radioactive iodine, and the second one is no screening.
Yes.
Thank you so much. So that brings us to the end of this episode of Voices of Wisdom. I'm Dana Hartl, and it's been an absolute pleasure for me to host today's discussion on thyroid cancer and nuclear energy, debunking the myth, with Professor Martin Schlumberger. I really want to extend a special thanks to Professor Schlumberger for spending time with us today and sharing his incredible pearls of wisdom. If you have any questions or suggestions for future podcasts, please don't hesitate to email us at voicesofwisdompodcast@gmail.com. We have an exciting season coming up. Please stay tuned for future episodes when we will be discussing topics like what is oncocytic thyroid cancer. Another topic is radioactive iodine, unveiling the mystery. And then we've got a podcast set up where we will go around the world in 3 clinical case scenarios, just to name a few of the upcoming podcasts. And if you liked our podcast, please subscribe to our webinars, which air live every Friday morning at 8 a.m. Eastern Time. TIRO Multidisciplinary Seminars is a series for thyroid clinicians and researchers that covers breakthroughs in thyroid cancer research and treatment in the form of topical journal clubs, state-of-the-art lectures, multidisciplinary tumor boards, and lively panel discussions. So just visit tyro.expert/subscribe or click in the link in the description. Join us again next time. In the meantime, remember that Socrates, and I'm paraphrasing, said, "Wisdom is knowing how much we really don't know." So thank you so much for tuning into this episode of TIRO's Voices of Wisdom podcast.